Good afternoon. My name is Arman Draginov. I'm actually a final year medical student. I'd just like to thank the program committee and the moderators for the invitation to speak today. It's a pleasure to represent University of Toronto and University Health Network. Myself and the co-authors have nothing to disclose. So segmental resection of left-sided colorectal cancer invariably involves resection of the associated lymphovascular supply. However, there's still controversy regarding the level of ligation of the inferior mesenteric artery. High ligation, it's generally accepted that high ligation involves IMA ligation at its aortic root, and low ligation includes ligation of the IMA distal to the origin of the left colic artery. And the rationalization for one technique versus the other is related to one, lymph node harvest. However, recent randomized controlled trials from Matsuda et al. As well as Singh et al. Have shown no difference in survival or recurrence. And two, it was proposed that the high ligation might have potential for nerve injury. However, similarly, randomized controlled trials by Matsuda et al. Again, as well as Marie et al., which is the high-low trial, showed no clinically significant difference in sexual or urinary and bowel function postoperatively between the two techniques. So just to reiterate, the low ligation preserves the left colic artery, and high ligation, the anastomosis relies on the marginal artery. However, as we've seen from previous talks yesterday, anatomical variation does exist. Therefore, the objectives of this study was to evaluate the level of ligation of the inferior mesenteric artery with one, primary outcome anastomotic leaks, and two, complications and mortality within 30 days. We identified 798 patients with primary sigmoid or rectal cancer between 2002 and 2018 using linked University Health Network institutional and NESQIP databases. 45 of these patients were excluded for undergoing an emergency operation. That left us with 753 patients who underwent elective resection. A further 440 were removed for undergoing an open approach, and that left us with 313 that underwent a minimally invasive approach, and a final exclusion of 32 patients due to not receiving primary anastomosis. So our final cohort involved 281 patients, and the high-tie group had 158 patients, and we had 123 patients treated with low-tie. Looking at our patient characteristics, I'll just highlight some of the significant differences. High-tie group was slightly older and had more missing ASA data. However, there were no significant differences in the preoperative comorbidities, as you can see at the bottom of the table. Looking at our tumor characteristics, again with the high-tie group, had a higher proportion of rectal tumors, lower proportion of rectal tumors, and higher proportion of sigmoid tumors. They also had a higher proportion of neoadjuvant chemoradiotherapy, and were more likely to undergo laparoscopic approach. Examining our primary outcome of anastomotic leak, I'll just point out that overall for our cohort, the overall anastomotic leak rate was 4.3%. And in this study, we had 12 events requiring intervention for anastomotic leak, 5 in the high-tie group and 7 in the low-tie group. However, between cohorts, there was no significant difference in anastomotic leak rate with an unadjusted odds ratio of 1.85, and as you can see, confidence interval of 95% crosses 1. And similarly, adjusting for tumor location, neoadjuvant therapy, and preoperative comorbidities, similarly, there was no significant difference in anastomotic leak. There was also no significant difference in reoperation for leaks. And then moving to our secondary outcomes, major complications which involves Clavien-Dindo classification 3 to 5, no significant difference. And similarly, minor complications as well, no significant difference between high and low approaches to the IMA ligation. Once again, complications as a composite, there was no significant difference again as well. We also had no deaths within 30 days. So of course, this study should be interpreted in the context of certain limitations. It is indeed retrospective analysis, and of course, we can have confounding from unmeasured factors, especially diverting stomas. However, statistically, that in this case, it would be likely that that would be statistically collinear with rectal tumors and neoadjuvant therapy. Of course, selection bias and surgeon experience might be confounding as well. This is a single institution analysis. However, unmeasured confounding is more likely to overestimate an effect, and our study showed no effect. So in conclusion, there is an elective laparoscopic ligation of sigmoid and rectal cancer. There's no association between the level of IMA ligation and anastomotic leaks, overall postoperative complications as a composite, or mortality within 30 days. And taken in the context of recent literature, which I had mentioned at the beginning of the talk, the choice of the level of ligation should be made based on technical factors of length for the creation of a tension-free anastomosis. Thank you.